I'm Florina Goebel, community manager at CSATS, part of the Johnson & Johnson family of companies. And we're grateful to have this opportunity to discuss surgical learning during this challenging time during COVID-19. We want to provide a forum for surgeons to connect and collaborate live on their unique and personal challenges with COVID-19 thus far. And we want to hear your stories. So what is working for you so far? What's not working? And how are you navigating your ongoing learning during this very challenging time, especially away from the OR? So please comment below with any questions and experiences that you have to share with us so that we can touch on these live with Dr. Mark Soliman. And feel free to tag any of your friends who would be interested in joining this discussion. So with that, I want to introduce our guest speaker, Dr. Mark Soliman. Hi there.
Hey, how's it going?
It's good. So as by way of introduction, Dr. Mark Soliman is the System Chairman of Colorectal Surgery at Advent Health Central Florida, Assistant Professor of Surgery at University of Central Florida, Program Director of Minimally Invasive Colorectal Surgical Fellowship, and the Associate Program Director of Colon and Rectal Surgical Residency at the Colon and Rectal Clinic of Orlando. Dr. Mark Soliman is also a paid consultant for CSATS, and the disclaimer should show up here. In stream, there you go. And Dr. Soliman, we are so glad to have you. I don't know how you do it. Those are a lot of titles that I just said.
There's a lot of colon and rectums in that title, but I appreciate it. It's a lot of fun to be able to be with you, Flo, today. Thanks so much for having me.
Excellent. We also have Crystal Massey from the CSATS team joining us as well. And she is the Senior Director of Commercial and Marketing at CSATS with J&J as well. And we are happy to have her lead this discussion with you, Dr. Soliman. So I'll kick it over to her.
Great, thanks.
Thank you, Florina. Hi, Dr. Soliman. It's so good to see you. Well, as we know, we're all dealing with COVID-19 challenges differently, and we're eager to hear from you today on your thoughts and guidance on how healthcare professionals are solving for some of these challenges in surgical learning. For those of you who are just joining us, we are discussing with Dr. Mark Soliman how he is advancing and supporting surgical learning through COVID-19 pandemic. Please chime in with your comment below, as we will be touching on these during our audience Q&A session. First and foremost, Dr. Soliman, how have you and your family been?
Yeah, thanks a lot. No, thank God we're doing okay. Right now, I'm in Orlando, as you know, and Orlando has been basically in a state of preparedness. We have been hit relatively, I'd say moderately hard. We've stopped doing elective surgery, so the family is good. Patients are good right now. We're gearing up for a big surge, what looks like to be in the end of April and the second week of May. So in that time range, from an administrative level, we're just kind of hunkering down, getting ready for it.
So you mentioned something that I think is very genuine and eager for all of us to talk a little bit more about. So elective surgeries, they're being canceled, or at a minimum, they're occurring less frequently. What are some of the challenges that you and your colleagues are experiencing in terms of elective surgeries in this time?
Yeah, I mean, responsibly so. And almost every single surgical society, and even the governor of Florida, has mandated essentially that every single elective operation be canceled. You know, it's a struggle because, we're surgeons. First week, it was kind of nice to get a little bit of a break. Second week's getting a little bit old. Now it's getting quite, we're getting quite fidgety, not being in the operating room where we've lived essentially for our entire careers, and, feel like there's skill degradation. There's kind of cerebral degradation in some respects. And so the way we're dealing with it is unique across the board. I think a lot of us are, we're still seeing patients by telemedicine. We're still doing didactic lectures, essentially within our fellowship. It's doing live webinars with societies. We're attending webinars with societies. We're trying to keep cerebrally engaged. And from a technical perspective, we're trying to stay engaged as well by still doing, of course, more urgent operations. It's a challenge also, as you can imagine. And we're a big private practice group at the Colon and Rectal Clinic of Orlando, and so it is a financial challenge as well to do this. But it's the right thing to do for the interest of public health and to flatten the curve, and also for conservation resources. I mean, we got to do what we got to do to play our part.
Well, and you're right. I mean, everyone has to do what they have to do right now during this time. Dr. Soliman, I've known you for years, and you've always been such a big thought leader in colorectal surgery, and it's really been the result of your relentless pursuit to continuously advancing your surgical training and learning. So, you're talking about the challenges that you're facing. I'm really curious to understand how you can continue to drive your own surgical learning. And I also know that in this time, you teach fellows. How has this impacted your ability to train your fellows as well?
Yeah, no, I don't deserve half of what you just said, but I appreciate it. We do have 2 fellowships at our program, an ACGME accredited colorectal fellowship and a minimally invasive fellowship as a part of the fellowship council. So 5 fellows between the 2 programs. And what's near and dear to our heart is surgical education, teaching. And, one of the reasons I joined faculty was because of my deep desire to stay in tune with surgical education, because it pushes me, I feel, to be better and to continuously innovate in both surgery and professionally and personally. And I think that what this time has really afforded was for us to really get creative with how we do that. And at least from my specific perspective, from the clinical standpoint, I mean, we've been innovating in ways that we never thought we'd have to try to see patients. So, for example, we've been doing tons of telemedicine now to stay engaged with our patients, to make sure that those that don't need to come into the office can stay out of the office. And then we've been essentially triaging them. And when they really need to come in, then we bring them into an office session to be seen or to be scoped or whatever the case may be. From a perspective of professional development, it's been interesting because articles that I've been dying to read for years now, I'm now able to read. Manuscripts that I've been dying to write for months now, I'm now able to write. Videos that I've been wanting to study or to watch or to develop or to edit or whatever the case may be. Now, because of this unforeseen downtime, it's been a blessing in disguise and the silver lining of this to actually be able to get that. And I know that at least in the position that I'm in right now, it's kind of the calm before the storm, because I know that, God forbid, in a few weeks, we're going to get hit relatively hard. We're estimating about 20,000 patients surge into one of the hospitals here in the Central Florida Division at the end of April, and then another surge at the mid part of May. And so we're essentially hunkering down before the calm of the storm. And so we're just doing what we can to kind of stay sharp mentally and technically as well.
Wow, Dr. Soliman, thank you for sharing that. I mean, there's a lot of stuff there that I would like to dive into a little bit. But for those of you that are just joining our discussion, we're speaking with Dr. Mark Soliman, who has shared some of his own challenges with surgical learning during the time of COVID-19. And I'm sure many others are experiencing the same as Dr. Soliman has. We were talking a little bit more about, learning and how you're driving your virtual learning and keeping your skills and not allowing those, your degradation of skills to occur from an operative standpoint. I'm really curious, really, how are you, or what's your thoughts on how surgeons can really focus on the non-operative skills right now?
Yeah, and that's a great question. I think there's never been a better time, even though we are physically disconnected from each other, a lot of us. We have never been socially more connected between social media, between all the publications that are going on right now, between all the social outlets, whether it's Twitter, Facebook, the CSAT surgical community, whatever the case may be. We've never been more socially connected. And therefore, I think with that comes a tremendous amount of opportunity to actually then study and do the non-technical development that we've been probably lacking and needing to do for quite some time now. So, for example, I mean, there's been a big debate within the literature and on social media and even within our own institutions about surgical smoke development and fulguration of tissue during cautery for minimally invasive surgery and open surgery, whatever. And it has spawned, at least for me personally, a tremendous interest in what the data looks like, what the data doesn't look like, what some of the false assumptions are, what the true assumptions are, and what the gaps in the knowledge are, and what we have to fill. And we've been able to actually use that time to write manuscripts, publish videos, have webinars, and all that. And so I think from a non-technical perspective, with the silver lining of the blessing of right now not having as much clinical stuff to do on my plate right now, it's a little bit easier to do. But I know that I'm in, again, a very different position than some of my friends that are in, say, New York or South Florida, or in the harder hit areas where they're actually being physically pulled from the comfort of their colorectal practice or surgical practice into the ICUs or into the ER or into the medical wards to take care of patients that they haven't taken care of in decades. And for them, I honestly, my prayers and my heart go out to them. And you definitely, I'm thinking about you guys, and I know that we're all going to be there at one point. But I envy. I shouldn't say I envy, but I certainly look at these other colleagues of mine with definite inspiration and awe for the leadership and what they're doing at this point.
Yeah, it's a great question and thought. When we think about surgeons across, you were just talking about across the U.S. and the world, really connecting with each other and doing things that maybe they just don't do on a normal basis. I'm curious, what advice would you give those surgeons about how you can connect and learn from each other during this time?
Yeah, yeah. I mean, social media has exploded over this period of time in which COVID occurred. And so that's a definite way to advance non-technical surgical learning. So social media is a definite one. Twitter is very active. I think that most people agree, and I think even those in public health will agree, that a lot of the place where you need to get your data from to start, the anecdotal data, of course, is actually Twitter first or Facebook, because that's where we're really discussing in a live dialogue exactly what's happening at our respective institutions in our respective cities. But yeah, I mean, social media is a big thing. And, and we're talking about CSATs today. I mean, CSATs is huge. Now we finally have an opportunity to look at best practice videos and what exactly an IMA pedicle takedown should look like, what exactly a right colectomy should look like robotically, or what exactly a lower anterior section or a total mesorectal excision should look like. But when you combine, say, Twitter with, say, Facebook groups and with the CSATs and with all these things that we're doing, you get the sum. The sum of all these smaller parts is a massive benefit, and massive amounts of data out there and information that we can use to really, really, really progress in surgery in our own personal education, as well as those of our trainees, and also in the greater community of medicine at large.
Well, we all know that you really take passion in helping others. In fact, I mean, your YouTube channel that you have out there is really fantastic about how you look at different procedural techniques and different ways to connect. How would you, if you were giving advice to CSATs, how can we help? Or even from the Johnson & Johnson perspective, what can we do to help during this time?
I think, Crystal, one of the things that is always amazing to me is that CSATs is probably one of the best kept secrets that, at least, I hate to call it a secret, but my God, it's like I have as many lectures as I give and as many people as I talk to. CSATs is one of those platforms that at least I personally and professionally have been able to utilize to really amp up my surgical game. And so I think what I would do from your perspective is just get the word out. Tell them what CSATs is, how they can access it, what they can do with it, the videos that are available on the platform, because there's a certain part of it that's free, which is awesome. I mean, I think the worst part about it is that your hospital, in order to send your videos in, there's a part to it. But I think that one of the most amazing things about what you guys offer is an algorithmic, evidence-based way in which to judge your surgical technique. And now is a perfect time to be able to showcase what this product actually is.
Well, we really appreciate that, Dr. Soliman, and we will definitely do everything we can to help out there. One of the things I always like to think about is just during times of uncertainty and times where we really don't know when the end is near, when that end is going to be. What advice or, how would you tell surgeons or really any clinician or person out there to stay productive and positive during these uncertain times? How would you go about saying that to them?
Yeah, I mean, I'm the last person I think that would be qualified to talk about that. And the reason I say that is we are all in this together. And I polled and have discussed this with dozens and dozens and dozens of colleagues, hundreds of colleagues, in fact, with this specific question. Like, what is everyone doing to bide our time and to kind of get through this unforeseen and this ridiculous pandemic to get through? And really the advice that I've received from the collective many that have contributed on social media and those I spoke to personally echo really the same things. I mean, if we're able to spend some of the time at home, this is an amazing time for us to reconnect with family, to reconnect with friends that we haven't been able to do so in some time. Amazing time for us to now start doing a personal audit, whether it's specific goals setting, whatever the case may be. And then from a personal side as well, you have personal exercise and whatever else. A lot of my colleagues and friends have told me that they've used this time to really hone in on their physical regimen and exercise regimen. From the professional side, there's been a tremendous amount of people reaching out, talking to me about how they're actually now finally reaching out to patients that they haven't seen in years, or those that are non-compliant bariatric patients, for example, those that are rectal cancer patients that have been lost to follow-up, now finally reaching out to their patients, talking to them by telemedicine or by phone or whatever the case may be, to get them back in, re-engaging with the community of patients, or even those. And one of my partners is doing a great job with this, is actually reaching out to primary care physicians again, essentially remarketing himself and remarketing the practice. Say, hey, the whole world is shut down, but we're still seeing emergent cases. So don't be shy. Send us stuff if you need. We're still taking care of it. So don't worry, you're not on an island by yourself. And so I think that those are at least from the professional and personal aspects of what to do when you're not in the physical brunt of the pandemic. From the physical brunt of the pandemic, those, my friends that are in New York, those that are in South Florida, those that are all around the country that are just getting beat on the front lines in the ICUs. And I know, hopefully not, but God forbid that we're going to be in a couple of weeks here. They're using this time they're in the hospitals pretty much all day, all night. And what they're doing is they're going to societal recommendations to brush up on ventilator management, antibiotic management, critical care management. Most of us in surgery, we did at least a 5-year residency, pretty much all 5 years of trauma and critical care. So we know how to run a vent. We know how to manage dying patients. So it's kind of old hat, if you will. Now it just takes a little bit of practice to get back on the boat, essentially. But from my colleagues that I've spoken to in the actual front lines in the pandemic side of it, it has been something that they've been able to use to professionally raise themselves up to the occasion. But I think from the global side, what's wonderful, I shouldn't say wonderful, but what is the silver lining of all this is that we as surgeons are now able to lead a team. We become, and we are perceived as leaders within the community. We're perceived as leaders amongst our colleagues, leaders amongst the programs that we're in the hospitals. And this is also a time to elevate our status as leaders and to really help lead our patients, our hospitals, our wards, whatever the case may be, through this pandemic. Being able to read on evidence-based medicine, being able to read on best practices in surgery, best practices in pandemic management, even though that's, a lot of the data is very murky, but we're able to take this opportunity to do the best that we can and become contributors and solvers of this pandemic and locally lead our institutions as well. I think that's one of the silver linings to this.
I could not agree with you more, Dr. Soliman. And in times when it's very challenging and we think about all the negative, there's so much to be positive out there. And I know it's hard to see it right now. We have a chance on an everyday basis to talk to surgeons like yourself and healthcare administrators. And, from the bottom of all of us, we say, thank you so much for everything that you guys do. But I also believe that no matter where you are and what field you're in or where you are in your life, there's things that we can do during this time, which is really enhancing our own learning and education. And I can tell you what you talked about teams and being leaders really has resonated with me. And, I think we're on CSATs, we're really starting to do that, a lot of that team building and really just collectively trying to understand how we can be more productive, but be productive in an empathetic way. And how can we really reach out and understand what people need and really answer that calling. So I'm sure at this time we probably have some more viewers wanting to chime in. So Florina, I'm going to ask you if there are any comments we'd like to bring into the discussion now.
Absolutely. So now is a great time for our audience Q&A. So folks, if you have any questions or comments for Dr. Mark Soliman or Crystal to speak to, now's the time to do it. We want to know how you're faring thus far in the pandemic, and what are your thoughts on how to stay connected and sharp while away from the OR if you're a surgeon. We want to hear from you. So we do have a few questions here that I will put up, and you can speak to that, Dr. Soliman. We have one from Sophia McCoy here from Houston. With regards to telemedicine in the future, AC after Corona, what role do you think telemedicine will play? So this is great because you touched on this briefly with Crystal here.
Yeah, I have personally been a very, very, very vocal proponent of telemedicine about 5 years ago. And then it didn't catch on. It was kind of a tough thing. Like, we were pushing it, trying to get patients to actually show up for telemedicine appointments. Insurance companies weren't paying for it. It was tough to convince patients to do it. Even getting doctors to do it. It was just miserable. So I think that, Sophia, like to your point, what's going to end up happening, I think, is there's going to be certain things that we've learned and perfected during this pandemic, and then it will persist after this thing is done. So, for example, telemedicine. I think that, like at least for colorectal, I think there is an inordinate amount of patients that I'm able to see. I'm realizing this now, that I don't need to see physically. I can see pre-ops by telemedicine very easily because I don't need to re-examine them. I've already had a relationship with them. I don't really need to see patients that live 6 hours away that I have to get in a car or in a plane or whatever to see me for an initial consultation. I can certainly just say, let's meet by phone first, or let's meet by telemedicine, by video conference, or whatever. Let's talk about this first. Let's share imaging, whatever the case may be. And then I'll bring you in for the day of your procedure, for example, and then we can meet face-to-face then. So I think that telemedicine in the AC era, I think certainly will be something that is a positive holdover and a silver lining that actually propagates further. Another thing that I think that's going to end up being a big deal that holds over is, hey, look at this. I mean, we're all over the country. We got somebody from Kentucky, you got someone else from Houston, you got the flows over in there in Seattle. I think that we're going to end up seeing a lot more of these interconnected webinars and videos being done for surgical education, medical education, just conferencing in general. I mean, how many meetings have you had canceled and gone to remote, and they work just fine? And I think we're really learning that we don't really need to be face-to-face for every single meeting. However, there's a balance because we are social creatures. We have to have social interaction. That's why a lot of us are going absolutely nuts and stir crazy right now. So I think there's going to be a balance at the end of all this. It will equilibrate, I think, in a very positive manner.
So piggybacking on that question, Dr. Soliman, how has your personal experience been incorporating more telemedicine into your practice?
So my personal experience, I'm on the nerdy end of the spectrum. So I love tech, I love video, I love all these things. And I have always thought that this is, I think, where we need to go. So for me, it's been a great addition. I enjoy it. I think it's going fine. A lot of my patients very, very, very much enjoy it because they are resistant to coming in the office. They don't want to get infected. They don't want to have any issues. So my partners that have been practiced for much longer than I have been have not have as good as a positive perception as I have. And again, I think that there's a spectrum of perception, spectrum of success. And I think the truth probably lies in between somewhere, where we need to do, of course, some live patient interactions, some remote patient interactions. So I think that the balance will certainly lie in between.
So our next question here also has to do with after Corona or AC. And this
The
is
AC
from
era.
Christy Ackerman. Do you think there will be any permanent changes to the way surgeons operate AC?
Yeah.
Will there be changes to sterility, masks in the hospital, etc.?
So, Christy, I think that's a great question, and I don't think we know the permanent answer to that. I will say this though: if what we are speculating is correct, then the answer to this is absolutely. Let me explain. One of the biggest reasons right now in the hospital, at least in the operating room, we're talking about N95 masks and being PPE head to toe, is because of the lack of knowledge that we have on whether or not COVID-19 can be aerosolized in an infected patient. We don't know if it can or not. We speculate that it can, and we assume that it can because HIV can, HPV can, and all these other viruses can, and other coronaviruses have been shown to aerosolize with cautery. So we presume, even though we haven't proven it, we presume that COVID-19 also can be aerosolized when you cauterize tissue. I think short of us disproving that theory, short of us saying that no, in 1,000 different studies, we have never been able to prove that COVID-19 becomes aerosolized, short of us demonstrating that, absolutely, the landscape's going to change. I think that the days of us strolling into the operating room to check up on a friend of ours operating without a mask on, or for me to just take my mask off when I'm doing a robotic operation and chewing, I won't say that publicly, chewing gum, but whatever the case may be, I think that there will be some permanent changes that are probably going to end up needing to be done in order to maintain safety for the clinical staff and for everyone that's out there. And I think that some much needed things, but I think that also it's very early in studies for us to truly understand how high risk COVID-19 is for tissue transfer, cautery and fulguration and smoke transfer. Now, of course, respiratory transfer, it's a bad actor. And I think that once we also figure out how better to test this, how to have a less false how to have less false negatives, how to have a more rapid testing processes in place. I think once we get to that point, but until we get to that point, rather, the landscape's going to completely change, I believe.
Mm-hmm.
Excellent. So we have another one from May Scott Thomasy here. What would your recommendation be to a second-year resident wanting to advance his or her surgical knowledge at this time? Where would they start in CSAT?
That's a great question, May. And I think probably the best thing to do is, it depends on what you want, where you are and what you're doing and what resources you have available. I mean, CSATs is a fantastic platform that offers best in class operative videos, whether it's colorectal or urology or thoracic, whatever the case may be, you have them all there. So absolutely visiting that to see what videos are available and how to propagate your education, I think is definitely needed. I think, but also from a technical perspective, not just a video review perspective, but from a technical perspective, there's no better time, honestly, to jump on a simulator, whether it's a laparoscopic simulator or a robotic simulator, or even more important, I feel, is to do your own personal video review, which if you have access to your own videos, I promise you, that will be one of the best things that you can do to advance your surgical career, is to review your own videos. So if you're able to do that, do that. But short of that, simulation work, and plenty of it, because there's plethora of studies that are shown how important surgical simulation is, whether it's endoscopy, laparoscopy, or robotics. Video review is crazy important, and also your personal video review is off the planet important to do.
Excellent. We also have an additional comment here from Dr. Kondra. Hi there. It says, yes, great point. We are all in this together. More sharing with each other in a positive way. Teach each other in a non-confrontational way. That is what CSATs is about.
Yeah. And James, I you hit it on the head, man. I think that, teaching in a positive way, I think gone are the days, honestly, in most of our careers where there's benefit to throwing a scalpel at a student or throwing a resident out of the operating room. And I think there's, I grew up in med school. That's how it was. You have to, I remember my attending would say, you got to put your hands right here. So I know not to throw the scalpel on your hand, or I know not to throw any sharp object in that direction. So I think you're right, man. In a non-confrontational way, that's just the way I think that's just the way it is at this point. And I think that CSAT certainly does it. As well as social media, as well as these closed Facebook groups, Twitter, etc. For sure.
Perfect. Our next comment and question is from Josefa. It says, once the lockdown is lifted, a second surge is expected. What should surgeons do now to prepare for learning in future lockdowns? That's a great question.
That's a great question. I don't know that I can answer that. I think that whatever we're doing now is probably setting the stage for future best practices and what happens in another epidemic, another pandemic. And because I think that it's clear that, this was not an anomaly. This is probably something that's going to happen again, whether it's in a cyclical manner or happen again in 5 years, 15, 20 years. So I think that what's nice about, I shouldn't say nice, but again, what the silver lining about this moment in time is that this is an inflection point in history where we are now able to decide how we're going to manage ourselves in this pandemic and how we're going to manage ourselves in future pandemics or future states of mass social disruption. So I think that what we should do now is personal introspection, figure out how exactly do we learn. Do we learn by being in a hospital? Do we learn by video review? Do we learn by reading? Do we learn by a combination of all those things? And then when this happens, we at least know what we can do to further our surgical and medical education at that point, and use the time that we do have at that point to actually then re-engage ourselves in those manners of education that we know work for ourselves.
Mm-hmm. Excellent response. Our next question is from Ravi Nagubandi. I apologize if I botched that up for you, sir. It says, what is the role of telementoring now and AC? Do you see it becoming more doable? I am a general surgeon in a rural community, and I see telementoring from experts in certain areas of practice can be a great help.
Yeah, Ravi, that's a great question, a great observation too. Let me tell you, so personally, I've done a lot of remote telementoring, not because I'm anything special, but just because I've had the pleasure and honor to train about 60 fellows now within our own program. And so a lot of those will go out into the community, they'll be stuck in a case, and they'll call me up on FaceTime. And then they'll put the iPhone or whatever the case may be in the surgeon's console, and I'll actually see, okay, lift this left arm up, do this, do that, and we'll help troubleshoot together, essentially live. And then we'll do a live case debriefing afterwards. We'll pull up videos and we'll do some what's called asynchronous case debriefing, or asynchronous case observation, if you will. The challenge always with that asynchronous case observation, or these asynchronous times, or even synchronous where you're live streaming something out, has always been a technical limitation of whether or not the feed was strong enough, or the video that you're sharing is choppy enough, depending on what's called the frame rate, or how fast the video is processing, and how strong your computer is. And so within this COVID pandemic, I've actually had time to nerd out and figure out how best to actually do this. And so now I think that I'm pretty well prepared now to be able to live stream operative videos to public channels, whether it's YouTube or Facebook or whatever, with the least amount of choppiness possible, so that these areas of practice and people that are in telementoring sites that in remote areas can receive better telementoring as opposed to perfect telementoring. I mean, it's not going to be perfect because you're not there, but it's better because you can be there, you can be anywhere, and you can be scalable. So I think, again, we're now socially more connected than ever. Technology is there. You just have to know how to utilize it.
I completely hear you, Dr. Soliman. In fact, I've heard stories from surgeons who are consultants globally, and all the yellow tape they have to cut through in order to mentor another surgeon in an OR. It just is flabbergasting to me. the time and resources it takes to make that happen.
Yep.
But leveraging 21st century technology allows for digital telementoring from the comfort of your own home. So thank you for that. Our next comment here is from Andelson Mariska. I hear surgeons are prepared to work nights and weekends once we get back to doing elective surgery again. Do you feel there will be a huge increase in surgery and patients coming into hospitals once hospitals allow elective surgery to take place?
I mean, I think it's only inevitable. I mean, we've been putting off elective surgeries for weeks now. I mean, I personally canceled, I think, 15 elective colectomies over a 2.5 week period of time. Those got to get done.
Mm-hmm.
You know, they're not dying, thank God, but those are gonna get done. And so, whether we're going to be staying late at night or working into the weekends or whatever, I mean, the docket's going to be full. So yeah, I mean, Anderson, I think that it's going to happen where we're going to be putting some extra work to get these cases done for sure.
And then Amy Gray Duval says, we hear about residents being accelerated through their last year to contribute on the front line. How do you foresee this affecting residency programs across the country?
Yeah, that's a great question. You know, the ACGME had a public statement on this exact thing, and what they basically said was that they didn't advocate. They didn't really like it, and I think the idea was it was more not necessarily on their preparedness to practice or preparedness to help. It was more about that if we accelerate them through, somebody still has to supervise them, and then what happens? Who pays them during that period of time? And then once we figure out who pays them during that time, are they going to be delayed in their start time at the new residency? And how does that work? Where does the transition occur? Is that a violation of their next contract at their matched hospital? So I think that there's a lot to digest in that one specific question. And I know that the ACGME had a public statement that was discouraging hospitals, at least in the New York area, from doing that very thing. But the reality is, I mean, sometimes we just need hands on deck to help out. And I think that whether it's done at the capacity of a student or done the capacity of an intern with proper supervision, I think that you do what you got to do in these times of public crisis.
So we have another one from Kaylin Cluvey. And this is more praise towards you, Dr. Soliman. Thank you for your continued support for patients and operating room staff during these uncertain times. Your outspoken knowledge is appreciated. So,
Sophia, good to see you.
But I share that with you as well. And a shout out from Brenda Cortez. Thank you for all your knowledge.
So I am incredibly blessed beyond description with a phenomenal operating room team, and I certainly do think that if you can surround yourself by great people, you will have great outcomes. And Brenda and Kaylin and several people that are on my operating room team are incredible blessings to me. I very much appreciate that, and everyone in the hospital that I'm able to be blessed to work in.
Perfect. And I think we have time for one more question here. This is from Israel. Will PPE be a limitation on going back to doing elective surgeries?
I mean, PPE is one of those things that it's certainly one of the rate limiting steps for us to do surgeries at the moment. And we're in a time right now, Israel, where, as you know, that it's not a matter of should we do elective surgery. It's even if we could do elective surgery, we would have to use PPE because of the COVID unknown patients, because we're essentially treating everyone as COVID positive, whether they have it or not, because of the 30% false negative rate on the COVID-19 testing. So I think that right now it's an effort to preserve the PPE for those that are legit at the front lines and in the mix that really need the PPE. We don't want to obviously utilize that or overutilize it. So I think that maybe in 3 months, 6 weeks, 3 years, whatever the case may be, who knows what the landscape's going to look like. Maybe the factories are going to be producing enough PPE to where it's a joke and we can actually not have that be a rate limiting step. But I think it's certainly a consideration that we have to make. and something that certainly needs to be discussed if we actually do need full PPE and 95 masks, whatever. And I don't think we know the answer to that until further studies are done into smoke evacuation, whether COVID-19 is in smoke or not, how COVID-19 is transmitted during an operation itself. I mean, there's a lot that unpack there. And I don't know that we know the total answer to it, but hopefully soon we will.
Excellent. I believe we can wrap this up. Dr. Soliman, thank you so much for your thought leadership on this important topic. And Crystal, thank you for leading our discussion. And to our viewers, big thanks for tuning in and engaging with us. We invite you to continue the conversation at csats.com. This broadcast will be recorded and available on our public Facebook page for later viewing, as well as at our website at csats.com. I hope everyone has a great evening and stay safe. Dr. Soliman, again, thank you so much for your time.
My pleasure. Thanks so much for having me.
Bye.
Bye.